This is a young individual, a 300-pound, fell down on the first metatarsal cuneiform that required fusion, as you guys can see, about a year and a half to 2 years ago. The hardware has been since removed and healed very, very nicely. So if I may point to it, as we can see, this was fused very nicely. The hardware, which was a plate and screws, also removed. Since the patient has a flat foot, some doctors do believe in medial column, which is the inner column of the foot reconstruction for a flat foot reconstruction. I'm not a big fan on its own. I usually look at three planal anomalies, which is the rotation called the frontal plane, the side-to-side transverse, and the sagittal, which is the up and down. So those are the planal anomalies that I like to look at. When we look at his foot, clearly we can see a little bit drift between the two lines. We call it a break in the cyma line. You'll see it more clearly as well on the side profile. More so as we look at it, the foot, when we look at it from a standing profile, this is his regular stance, which is standing. As we can see, the instep is going outwards. The ball, which is popping outwards, some people call the bulgers and escape. This bone, called the cuboid, with this bone is not parallel to each other as a straight line. So these mid-tarsal bones are going outwards, creating an abduction of the forefoot. So as we can see, the hind foot is going inwards, and that's why he feels the bulge on this side, the instep going outwards, and followed by a rotation as well of the forefoot. So this is what we see from the AP view, which is a top to bottom view. And then when we look at the side profile, clearly we can see that those are not even, called a lazy S. There's kind of a drop off. So there is about a good centimeter. This should be further down. And so that's the intention, is to break it right there, called an Evans, distal calcaneal osteotomy, and put a bone graft from a cadaver. I like to using iliac crest to extend the bone further, and so therefore it has a shelf. And so this ball stays in the socket, doesn't escape. And so then aligns the cyma line, and there's no break in it. They call it anterior break in the cyma line. So anyway, as we look at it in this respect, that is what is going to be done. Also, the Achilles will be lengthened percutaneously according to Hook, which is a percutaneous stab incisions, 3 of them, to allow further elevation by weakening the Achilles structure by a grade, allows elevation of this heel bone upward, and so therefore the kite's angle would be also reduced. So that's on an X-ray standpoint. So again, it was a medial column that was addressed, and unfortunately, in his situation, the flat foot did not like it, and it will require 3 different procedures. So now when we look at it from his foot, as we can tell from a side profile, I try to lengthen, try to stretch his heel bone at the ankle joint, and it just doesn't want to move beyond 90 degrees. And regardless if you bend his knee, which you can, please, it doesn't move at all. And so that is a gastric soleus equinus, which is both apparatus of the back of the calf that is tight, that requires to be addressed, rather than a single structure in the calf, or a bone block typically in the front of the foot, which we do not see on X-ray in front of the ankle. I apologize. So in this situation, an Achilles lengthening is definitely a plus for this individual to allow the sagittal correction. He will require also the distal calcaneal osteotomy called an Evans. As you can see, his foot, when we pull up, it wants to go outwards. It wants to go outwards, as you guys can tell, and that will be addressed by a wedge into the side of the heel. And so those are the peroneal tendons, if you guys can see them right there. So the incision would be further, slightly above, and further away from the joint, calcaneocuboid joint. And at times I pin it when I break the heel bone to make sure that there's no subluxation or dislocation of that joint upon inserting the wedge. And that's very, very basic procedure. And then I usually either put a staple versus a neutralizing plate, which is a 2-hole versus a 4-hole X plate. So in this situation, as we can clearly see, there's a little nub as well called a Kidner's procedure. Works phenomenal for this. So we'll ligate the veins a little bit and get to a small little incision and shave this down and bring two absorbable sutures and bring the tendon further back up. That will elevate the arch. So I'm going to change hands, if I may. As I do this, it becomes up like such. So the pull of the tendon has a better grip. It's called a transposition of the posterior tibial tendon, and that is what he needs. And so therefore, when I do perform these procedures, I always start from here to get adequate sagittal motion, which is the top to bottom correction, and then I go on to the inside, which is this little bone that we showed you, as we can clearly see, bulging right there. Every time he steps, it becomes profound and protrude into the area, as well as the ball in the socket starts to stick out. So that will be addressed, shaved down, anchored, and transposed. Then I go to the inside. So typically, if I did hypothetically this side first, this goes inwards and becomes a little bit more tricky in regards to addressing the bone. Believe it or not, you have to transpose then more of the tendon, more severance of the tendon, more complications. So it's best, in my mind, is to address it this one first, second, I apologize, then this third. So cut in the back called the hooks, a Kidner, and transposing the tendon, shaving the bump, and then followed by the Evans calcaneal. Now, since he had surgery on the top of the foot, and that was fused, he is also complaining of bone right underneath, right there, of the fusion site. And that could be also relieved with just correcting the foot by elevating it. But since this is slightly protruded, I'll do a little slit to kind of round it down very nicely and to relieve the pressure of the nerve that he's complaining, as well as the fascia. And he's getting a little bit of a fibroma, which is a mass of the fibrous tissue of the plantar fascia, which I'm moving around right there. That will be addressed with that little tiny incision. So in a nutshell, this is a foot that will be reconstructed. As I try to pull the foot upwards, it goes outwards rather than upwards because of the stiffness of the calf and the tightness of the calf of the Achilles apparatus. It will require stabilization of the hindfoot on the inner as well as the outer part, rather than just addressing the inner part, as some doctors do perform. This individual had a beam fall down 300 pounds that required fusion, and usually they heal very, very well. In this situation, because of his deformity of his foot type, it now requires further care. That requires the whole foot to be reconstructed. And so that is hopefully helpful to people who have a flexible or mobile flat foot. It's good education in regards to how to address certain structures, and hope that you can address these with your doctors, and especially the surgeon, that is, that what would be necessary, and has some insight in regards to the condition that you may have. Thank you.